And we're live. Hi, everybody.
Hi.
So I'm Dr. Stephen Phillips. I'm here with Dana Parrish, and we are so pleased to have our guest, microbiologist Amy Proal from Polybio. And we're going to be talking about all sorts of good things. Dana, you want to start us off?
Yes. Thank you for being with us, Dr. Proal. By the way, also, I never officially thanked you for the incredible interview that you gave us in our book, Chronic. We absolutely were blown away by everything that you told us. So I just want to put that out there first. And thank you.
Absolutely true. It was just full of quotables, full of sound bites.
Yeah.
I'm honored to be in the book.
We're going to need to just include the rest of that interview because it was so good. Anyway, so thank you. You are like a true expert on all these things that most people really have a lot of misinformation about, like persistent infections, the microbiome, what it really means to the microbiome to take antibiotics, congenital microbes, all these sort of hot button topics that you speak so clearly about, and you're so brilliant, incredible, and well published. Anyway, so thank you for being with us. Please talk to us about, we're going a little crazy, if you haven't noticed, about this post-viral syndrome, post-COVID syndrome, everything being attributed to an infection that is no longer with us. So in very plain terms, let's explain to people why we're so upset about this term and what it means going forward for patients that are suffering with long COVID, also with ME/CFS and Lyme, chronic Lyme. What do we make of it? Why should we not say it? And what do we do?
Right. So good point, Dana. I've actually been pretty frustrated lately as well. So with a lot of, I don't know, you kind of call them syndromes, it's actually very well understood that most major pathogens, in fact, I can't think of one that doesn't do this, viral and bacterial, a number of patients that get that infection in what's called an acute state, like the when you get COVID and those initial times when you're really sick, a subset of people will get chronic symptoms after that infection that never go away. And I think we're very familiar with the fact that that happens with people who are infected with Borrelia or the other pathogens that ticks can carry. But there's also a disease called myalgic encephalomyelitis chronic fatigue syndrome, or ME/CFS. That is a disease that almost always or very often starts with a viral infection. And then patients also, a certain number of patients, and common infections that start ME/CFS cases are herpes virus infections. For example, Epstein-Barr virus, which is the driver of mononucleosis. So, it's like mono, people get that in college. Well, some people who get mono, they never get better. They just get chronic symptoms that, to be fair, feel a lot like mono for the rest of their lives and are very, very debilitating. So it's this general trend where people get an infection and some people just don't get better. Now, how do you name this? What's happening to people? What's happened in the Lyme community, as we all know, is that patients who have ongoing symptoms after an infection with Borrelia, that tick,
which is Lyme. We should tell people, we need to really break this down.
Borrelia is the Lyme pathogen.
Yeah.
Those patients have been named post-treatment Lyme disease syndrome patients.
Well, they're named by some. That's not a name that we foster or advocate for, because we think that it puts people in a box, but the name by some. We have to recognize that there are divergent, views in the medical community, and each side has its say. It's hard to say post-treatment Lyme disease syndrome when the bacteria that causes Lyme has been isolated alive from patients after literally years of antibiotics, when it's, found in animals after the treatments that are purported to cure people. And when, those same treatments don't even kill it in the test tube. It's a very, very thin kind of non-logical, framework to say, okay, the same bacteria that's there and causes acute illness, the fact that we're finding it in later stages of these chronic conditions, we're going to say, well, we don't know what the cause of the chronic illness is. Meanwhile, they're finding the same exact bacteria that causes symptoms 1 through 10 in the acute setting. And now symptoms 1 through 10 are still there in the chronic setting. And they're like, oh, we have no idea. It's the craziest, lapse of logic.
Yeah, exactly. So you name it, a lot of people are being referred to exactly as post-treatment Lyme patients. And that word post is truly problematic because first, in that diagnosis, it implies two things. The word post means after. So it really it implies that the infection is gone.
Right.
That is a big assumption. Now, I can't tell you that I know that every person who has ongoing symptoms from Lyme has an ongoing infection, but it's certainly a very logical and big possibility. And as Steve said, there are quite a few research studies that suggest that that is indeed happening. In fact, I was just looking through one of my favorite papers, which is a study where, unfortunately, a woman was sick with Lyme for over 16 years and treated with repeated courses of antibiotics. And even then, when she unfortunately passed away, they looked at her tissues. They looked at brain tissue, heart tissue, liver tissue, kidney tissue, and they used different methods, to look for Borrelia and its genetic material. And they found it in all those tissues in this woman, and she'd taken many courses of antibiotics. So obviously, studies like that provide at least quite an evidence base that patients may simply have an ongoing infection. But if you name the condition post-treatment Lyme disease, first of all, it suggests the infection is gone. And second, I particularly dislike the post-treatment part of that, because what it also implies is patients who, after they get bitten by a tick and maybe they get Lyme in some way, then they're usually given a round or two of antibiotics, usually doxycycline. And for some reason, it is assumed that that round of antibiotics is supposed to have eliminated this pathogen from your body. And that's the idea of saying that you were given these antibiotics and you have ongoing symptoms. So now, how could it have survived that one round of antibiotics?
It implies that the treatment is a cure. It's like they can replace treatment with a cure. They're basically saying post-cure Lyme disease syndrome. Right. And we don't have evidence that these treatments are overly effective. We have evidence to the contrary. People should know that there's about a 40% spontaneous remission rate of Lyme symptoms on their own, and then they can come back again later on. So the fact that they're remitting with the antibiotics in the early stage doesn't really say that much in terms of cure. It doesn't speak to cure, certainly.
Right.
It would be a little like if let's say there was a cancer patient and they were getting chemotherapy. And we all know that chemotherapy doesn't work well for a lot of people. I mean, we try, but, some people, the cancer wins, unfortunately, right? So it would be like taking patients with cancer who didn't do so well in chemotherapy and now calling it post-chemotherapy mystery disorder, as in instead of just saying, the chemotherapy didn't fully get rid of the cancer. It's that kind of.
And to make that simile more complete, then they would have to then blame the patient. It's like saying you have post-chemo cancer and it's your fault. It's all in your head. You go a step further to make that kind of comparison more ridiculous. And then you realize what an insane situation the patients are in. And we've kind of I've certainly been there. Dana's been there. We've been there. And then let's pivot to COVID and the evidence of, is there still the virus present? And what are the dangers to long-term COVID patients who are being put in this box of post-infectious syndrome post-COVID?
Yeah, it's so worrisome.
It's definitely worrisome. I mean, so exactly, a lot of patients after they develop COVID are getting chronic symptoms, and there's a range of different people are developing lots of different kinds of chronic symptoms. So one thing I think is important is I'm not sure everyone who has still some chronic symptoms after COVID has the exact same thing going on. There's probably some people might just still have injured lungs and breathing problems, but there are certainly a subset of patients who are developing very debilitating clusters of symptoms that are similar to what ME/CFS patients or chronic Lyme patients get. And in those instances, an obvious, let's be serious when we're looking, let's say we're detectives and we're trying to figure out what's going on. The first scenario you think about is, what if the virus was in their bodies, but they weren't fully able to clear it from every single body site? Right. What if it's still in them? Doesn't have to be everywhere, but what if it remained in a reservoir, especially, and those reservoirs wouldn't be expected to be in the blood? That's a really important point, because the SARS-CoV-2 virus that drives COVID-19 disease barely travels through the blood, even in the regular, acute disease.
You need to tell people what that means. That means
break it down. So the virus isn't present in the blood in the acute phase.
Hardly.
And then when it's expected to be, when it's spreading through the body, and in the later phases, it's even less so, you're saying, right?
Oh, well, yeah.
It's very hard to detect.
Very hard to detect. And that's the thing, is one of the things that I think has led to a lot of these, what may very well just be in chronic infectious syndromes in many cases being called post this or post that, is that research teams, and a lot of them are well-intentioned, they'll take a blood sample from a patient with ongoing chronic symptoms. They look for an organism in that blood sample, and then when they can't find it there, they say, oh, they must not have it anymore. But what they need to do is think about the organisms that they're looking for, because most pathogens, and this includes the Lyme pathogen Borrelia, they don't like it in blood. Blood is where the immune system is. That's where all the immune cells are out to get you. So what they do is they go and they hide in tissue. In fact, they have many different ways in which they break tissue down to burrow deep into tissue. So especially over a longer period of time, you're much less likely to find that organism hanging out in the blood, trying to be targeted. And what you really need to do is look for it in tissue samples.
Right.
Now, that doesn't happen often. So that can lead to the misconception that people may not still harbor the organism. And interestingly, there's been a couple teams that have looked for the SARS-CoV-2 virus in patient tissue samples 4 or 6 months out in patients who still had ongoing symptoms. And in one case, they looked at the tissue of the nose.
Yes.
And in that study, they found the genetic material of the virus and proteins that it creates in some of the tissue samples from patients who had an ongoing loss of smell from the virus.
And we should make it clear that it was way up further than they can get to with a normal nasopharyngeal swab. So people can't just get proof of that the virus is still there.
So they were testing negative on a traditional test. And then when the doctors actually dug further, this was at the Pasteur Institute in France, from what I remember. And it's a very esteemed, think Mayo Clinic in the United States or something. These are amazing doctors. They actually thought, oh, yeah, let's see and one of the patients, I heard from her, and I know the two of you know who I'm talking about. She told me that she felt the virus replicating in her olfactory bulb. She said, I felt a gurgling. That was the quote. And then they said it was still active. And then the doctor said, and you were probably still contagious this whole time. They were all immunocompetent, which means they were all healthy people. And it was all, I think, 4 to 7 months out after the initial infection. So this is a really big deal, I think. This study blew me away.
So the problem is that researchers should know this, right? I mean, not to say, to express frustration or whatever, but microbiologists know this, researchers should know this, and yet there's a disconnect. Somehow, this very obvious thing of you can't find out all the infections that are present in a person by looking at 1 milliliter of blood is not being carried through. We know that's a wonderful quote, but it's not being carried through to the people that are doing the actual research. But they know this. It's not like they're ignorant of this fact. So do we have any idea about why the proper research hasn't been done? And again, bring it back to Lyme. They can't find the Lyme bacteria from the blood and fluids either. It's only by cutting these animals up. That's why we have such powerful animal data. I mean, the animal data about Lyme being chronic is ridiculous. It's like anybody would think, of course, we're not getting rid of this infection. We're finding it in such a high percentage of animals after treatment's supposed to cure people. But in people, we don't cut the people up, right? I mean, so it's inherently difficult to do these things unless you're taking surgical samples. What do you say to these researchers who are kind of either turning a blind eye or I don't know. What do you want to call it? Is it just they're incompetent? I mean, not to be cruel, but I don't understand why people aren't thinking along obvious lines of rational thought.
Yeah, exactly. I was going to ask you, why is this not being recognized? It is so obvious. It's obvious to a layman, a complete non-medical person. I do not have a medical degree. And to me, I cannot believe this insanity that's going on and ignorance. And then all of a sudden today, there was all this news about Ebola is persistent. We knew that. It's in our book.
Everybody knew that. Well, not everybody, but most virologists knew that.
Everybody knows this, right? Anyway, why is this news? Why is this so shocking?
Let's talk about that for a second with Ebola, that it can persist for a while. I mean, this is a virus that's so lethal. So obviously the characteristics of persistent and latent viruses are different than the acute setting. And, could it be that, so people, I think, should just understand that just because a virus persists doesn't mean that people have to remain super contagious the whole time. They're not, it's just a different phase of illness. And and that explains for the people that say, well, it can still persist because I didn't give it to my family, even though I'm chronically ill. Well, yeah, you're not expected to at this phase of the illness.
It's in your brain. It's in your kidneys. It's
exactly.
I'm going to burn my earpiece after this because it's officially fallen out like 15 times. If anybody watching knows of any earpieces that are small enough to fit a hamster, please let me know, because I have congenitally small ear canals apparently, and nothing fits my ears. Just put it out there.
Megan, do you have a little masking tape?
Masking tape. Just duct tape will be fine.
Duct tape
will be great.
Oh my God. Remember when we used to Jimmy rig my cell phone to take our videos?
No, I couldn't. I blocked that out of my memory. Our duct tape trials.
We're very professional. Anyway, I'm sorry for that diversion.
No, but yeah, Steve, what you said, that's the whole thing, is if these organisms burrow into tissue and hide out in tissue, then they're not necessarily in your fluids, and fluids tend to be what people pass between each other. So there's a lot less likelihood that people will be passing organism if it's in tissue. And also, if you really read the research on persistent organisms in tissue, they persist in really low levels. So it's usually what's called a low biomass infection. A very few number of cells remain infected. And those cells, though, what happens is those infected cells perpetuate. The immune system keeps trying to, target them, keeps trying to get them. So they perpetuate a lot of additional inflammation that, kind of cascades away from that low level infection. And, that the problem with that, though, is it really is a difficult thing to study, because how do you study the tissue of a living person? I can't, go into your heart and see if you do or do not have a virus or bacteria in there, right? In a living person. And also, if there's just a low level of the virus, even if I do get samples, I have to get quite a few samples in order to know if there's something there. Because, for example, we're collecting some tissue samples from surgeries right now, and we're collecting as many as we can because, even if most patients have organism in some of that tissue, the pieces that we get are tiny, right? So the likelihood that, a little bit of the organism is in, so you have to, it's a real effort to get into, a lot of tissue and find these things. And that really is one of the reasons why this isn't as big a research avenue as it is, because a lot of teams just don't go to the effort to do that, right?
There's something preventing this research from moving forward. Now, I got Lyme about 6 years ago, approximately. I have been baffled by this, and many other people are as well. Why is this research? We've gone, okay, let's just talk about the billions of, how much, 30 billion wasted in Alzheimer's research, not looking at pathogenic reasons for, infectious reasons for Alzheimer's. Now we know, even though there was research 30 years ago, and then nobody talked, it was just buried, and then nobody's looking for the right answers for the cause. And I just want to know, why do you think that is? Why is this so shrouded in mystery and illogical thinking?
Yeah, I think there's a lot of reasons for that. One of them really is coming back to what we're saying, which is a lot of teams, you have to be a microbiologist that really puts the time into understanding how the organism you study behaves in order to find it. And these days, a lot of people right now, research is very segregated. So you have people, for example, a lot of the people that make diagnostic tools are engineers. They're really good. They build, new technologies for finding things, but they don't necessarily sometimes just communicate with a researcher like myself, who really tracks what pathogens do when they're inside the body. So I've, talked to a couple of really well-intentioned people just in the last weeks who, for example, want to make a Lyme diagnostic, but they're going to just they want to do it for blood, right? And I'm like, well, that's a good start, and that might be good for the early stages of Lyme, but we have to consider that for the later stages, blood, we can try, but we also really need to probably innovate to figure out how we could do diagnostics that can reflect what's going on in tissue, right? So we have to be able to, because what will happen is some team will develop a really cool new test for the Lyme pathogen in blood. But if the Lyme pathogen is in every tissue of the body, but not in the blood, they're just not going to find it. They can be the coolest team in the world, right? there is some of that goes on because blood is the easiest kind of sample to get. That's what's drawn. That's what teams are used to doing. And some organisms are found in the blood more. Borrelia really isn't one of them. For example, there's a team at Harvard that we know, and they have these devices where they can, look at immune responses in live blood to an organism. And just 2 Borrelia organisms, the Lyme organism in blood, can generate a really profound immune response. 2. So even if 2 happen to be in the blood, those, it's really hard to find those. So
exactly. That's part of the problem. But what research, I wanted to ask both of you, what research needs to be done?
Yeah, I mean, I think that what we're trying to do, for example, is actually take a closer look at tissue. Like I said, for example, on patients who have ongoing Lyme issues, or also with an ME/CFS diagnosis that I mentioned before, doctors take what are called like small fiber punch biopsies from them. So they'll take a piece of skin that contains nerve out of their leg, or sometimes out of their stomach. And what they do is they count nerve fibers in those samples. And if the nerve fibers are damaged or decreased, they get a diagnosis of what's called small fiber neuropathy. But then after that, they throw the sample in the trash. And so what we're trying to say is, like, don't throw the sample in the trash. Yeah. That contains really valuable tissue and nerve, because, Borrelia and the herpes viruses, which are big players in ME/CFS, and even the SARS-CoV-2 virus that drives COVID-19 disease, are neurotrophic. And what that means is Bartonella, they infect nerves. That's their primary site of infection is nerves.
Talk to people about what those symptoms look like, because I don't think anybody really knows. They don't, it doesn't translate, I think, a lot of times when we talk about these things. What do you feel like when that's happening?
I mean, one of the main things is a lot of patients with a Lyme or ME/CFS diagnosis get this small fiber neuropathy diagnosis, and that can feel just very uncomfortable, tingly, pain, almost sometimes loss of sensation, problems with autonomic function, which is sort of like the system that regulates blood pressure so that people feel, do or do not feel dizzy, are able to move from a sitting to standing position without feeling as if they have to faint.
We have to talk about POTS, because that's been in the news a lot with COVID as well.
Exactly. What's dysautonomia is also tied to the activity of nerves. For example, there's a very, very important nerve in the body called the vagus nerve. And the vagus nerve is, it enters the back of the brain at what's called the brainstem, and then it branches into every main trunk organ of the human body, including the gut. And so this nerve is conducting signals between the body and the brain. And one thing that it does is, if it detects an ongoing infection or inflammation in any of those body sites, it will signal to the brain to say, problem, there's a problem here. And what the brain does to respond is mount what's called the sickness behavior response, which are flu-like symptoms and feelings of being achy. And, because what that is doing is the brain is saying, you're sick, you have an infection, you have a problem, rest. That's why, we feel flu-like symptoms when we get the flu. It's the brain, sometimes largely signaling through this nerve to say, you better lay down, you're sick, right? And so one of the things that our research team looks at in ME/CFS, and that we're interested in at Lyme as well, is this vagus nerve. Different patients someone could have an infection in heart tissue, someone could have an infection in liver tissue, someone could just have an ongoing issue in the gut. And those different situations could all signal to the vagus nerve to cause similar sets of symptoms that would affect the way that brainstem region of the brain signals. And the brainstem controls autonomic function. It controls lots of the sleep-wake cycle. It controls that sickness response. And those clusters of symptoms are very common in patients with Lyme or ME/CFS symptoms. Yes, and of course, the brainstem itself might be infected at a low level. In fact, there was one ME/CFS autopsy study that found enteroviruses, which are a kind of RNA virus, and their proteins in the brainstem of the patient who was autopsied. So it's possible there could be direct brainstem infection in other areas, or the vagus nerve itself could be infected. That's something that my colleague, Mike Van Elseker, came up with. He wrote a paper on that in 2014 saying, I think the vagus nerve, which is, also Borrelia infects cranial nerves like the vagus nerve.
So let me just simplify and summarize and also pivot a little bit, because this stuff is obviously really technical and want to make sure the viewers can digest everything. So we've talked about that the virus, SARS-CoV-2 can persist. We talked about with other conditions like B. burgdorferi, the Lyme bacteria can persist. There's other infections too, like Bartonella, Coxiella, tularemia, and this is a common theme. But the other thing I just want to mention that we haven't talked about yet, because, as the doctor doing this for a while, I see lots of patients come in with ME/CFS and able to get most of them better. And it's not really by treating with antivirals. So about 80% of my patients do get better. And I've seen patients who've come in with these diagnoses that have happened after bad viral bout, like EBV or dengue fever. And there are a lot of initial herpes viruses. Some of my patients report, like when they first get sick, they have herpes simplex kind of, outbreaks and shingles outbreaks. And I always wonder, chicken or the egg, like, did they have it before and they became immune compromised during their initial like Lyme or other infection, and that came out. But I guess what I'm trying to say is that the infections, these viruses, could they set the immune system off in some way? And then if somebody was latently infected with these other chronic bacterial infections, become asymptomatic and then go to symptomatic, because a lot of them have responded to antimicrobials that are not antivirals. Some of them, there's overlap, like monolaurin, a supplement.
And I think you have to even go back further and explain to people that you can have an infection and have no idea. That's the thing that blew my mind when I first got sick. I didn't realize that I probably had a low level of infection for a very long time because of all the bladder pain that I had related to interstitial cystitis since I was 5. And then when I started to treat with Steve, it went away fundamentally for the first time in my entire life. I mean, I would have periods of relapse and remitting throughout my life, but that's very typical with Lyme and with other organisms. I just didn't know. Nobody ever told me that there was a cause. In fact, they told me, they went out of their way to tell me they didn't think there was any cause. It's just the way you're made. It's your weakness. And I mean, I remember thinking like all my life, there has to be something else, but I just didn't know. So we should just say you can have an infection like Lyme. Lots of people are asymptomatically infected.
Or minimally symptomatic, and they've attributed something else. I mean, I literally cannot count how many times people come in, they say, I've had significant migraines for 10 years or significant IBS or significant, this like tricky joint I have. They're thinking about maybe doing a replacement. They don't really know what's going on with my joint pain. And we have 6 months of symptoms that are being diagnosed as Lyme or something else. I treat them for their acute situation and their chronic symptoms evaporate. I've seen it hundreds and hundreds of times. It's not a coincidence. And Dana, it's my stories in the book. For the people who have the book, they'll see that when I was, Amy, I don't know if you know this personal part of my story, but I was a healthy kid. And when I was 19, they went to a cardiologist for some different symptoms. And they said my heart valve was basically falling apart and I probably need heart valve surgery when I'm 50. And then when I got first Lyme, which was not a severe case of Lyme, it wasn't disabling anyway, but it was like annoying and kept coming back. And I got treated for Lyme a bunch of times. My heart valve, year over year, as I did the echoes, just got more and more normal with treatment for Lyme. And here I am now, 55. My heart valve is completely normal. Yeah. And the doctor said I'd probably need heart surgery. He's like, he's this like famous, New York City cardiologist. We went to the best of the best. He didn't like overstate it. You don't go from severely diseased heart valve to normal heart valve as you get older. It's usually the opposite. So I think that's what we should also think, that these infections are really common. They come in lots of forms, and people frequently get sick in layers. Like they get one hit, and then the second hit, and then the third hit. And like, let's say the third hit is one that takes them out. It's an accumulation of how many infections people carry. And then boom, you get this presentation. Okay, now they're going to call it chronic fatigue syndrome, ME/CFS, because you just had battling so many infections.
Yeah, actually, even when I was younger and in my graduate work, I actually coined the term successive infection to describe that. It's basically a multiple hit model. And what really happens as well with that is once a person has one infection, if that pathogen will usually hold down the immune system to a point, right? So most viruses or bacterial pathogens, in order to stick around and survive in you, they disable some part of the immune system to better stick around,
Correct.
right? Yep. So now that the immune system isn't so great in you anymore, if you get another infection, that pathogen can probably stick around a little more easier than it otherwise would have before. And it might also do something to the immune system to knock down its function. Right. Now, if you get a third infection, it's even easier for that organism to start causing problems too. And then, of course, not just infections, but other insults and exposures can feed into that same pattern. So if you're then exposed to mold, you might have problems where the mycotoxins, hold down the immune system. And that makes it easier for the pathogens to, again, persist or infect new tissue or nerves, right? Or you might unfortunately get an injury that just causes other forms of inflammation and, or just really bad periods of stress. And that's why sometimes people say, I was stressed out and I got sick. But what really might have happened is they already harbored a pathogen. But before that, the immune system was surveilling, keeping it in check, right? But then under this period of stress, which could be, for example, stress, a new infection is a form of stress. So that is, you brought up before, some people who get the COVID-19, disease, it can, debilitate you and dysregulate the immune response. And that is a real opportunity for other pathogens that you already had in you to reactivate and infect new tissue or nerves themselves, right? So in those cases, the COVID, SARS-CoV-2 virus may not even have to persist itself. Maybe it does clear, but in its wake, it leaves other pathogens that you used to control that are now active and able to drive new symptoms in and of themselves.
Yeah, so I totally agree with you. When we had, when I'm looking at patterns of illness when patients come in, because, people come with really complex histories, and it's not always I had a bug bite and I got sick. It's sometimes I had a virus like we just talked about. Other times is I went through this horrible divorce. I was really stressed out, and all of a sudden I never bounced back from it. Then I've had other people who had physical injuries, especially, believe it or not, head traumas, which I think are preferentially immune suppressive compared to other traumas. I remember a patient.
Can you explain what that means?
Head trauma, preferentially
immune suppressive.
So suppress the immune system more than like punching someone in the stomach, punching them in the head. I mean, or let's say not punching because it would be violent, but hitting, like falling and hitting your stomach or falling and hitting your head. The head is worse. And I've had patients with relatively mild traumas that were diagnosed with post-concussive illness, which is like, it's almost like post-infectious syndrome. It's like a long-term, primarily neurologic, but they're including like an ever-expanding spectrum of what's included in post-concussive illness now. Yeah. And I've seen some patients with antimicrobial responsive cases come in with that label too, which is so weird,
One of the things about the brain, when you're talking about brain injury, is that brain contains these cells called microglia. And microglia are the resident immune cells of the brain. So they're supposed to control infection. And microglia, they can become what's called primed. So if there's one, let's say they're being activated by one ongoing infection. The next time that something else also activates those same microglia, and that could be an injury, that could be another infection, they respond with an even bigger response than they would have otherwise, an amplified response. So that really allows the cells of the brain to even amplify the effects of multiple insults more than sometimes the rest of the body. So that could be why you find that injuries that affect the head or the central nervous system are sometimes the most debilitating, because those microglial cells will really respond with an extremely excited response to the next insult. And that can lead to that's, when people talk about neuroinflammation, what that means is that researchers are using scanning machines to see if those microglia cells are activated in your brain. That's what they're measuring. And so when someone has a neuroinflammatory illness, what they're usually saying is this person has a lot of activated microglia, right? So
let's talk about those symptoms. And then I want to ask you if COVID is activating these other latent infections that we just talked about that we may be harboring and not even realizing. Okay, so this is a two-part question. What are the symptoms when you have brain inflammation or neurologic inflammation, and then what's going on with these other infections in the face of COVID, do you think?
I mean, brain symptoms can be many. I think, an obvious one is what is called brain fog, which is a very innocuous term for what can be truly debilitating cognitive symptoms that can sometimes resemble dementia. So a lot of patients with ME/CFS or ongoing Lyme issues, they really have trouble thinking or remembering basic words or stringing together sentences. I knew a woman with ME/CFS who was a company executive, and she went to reading at about a 3rd grade level after she got ME/CFS. And she told me a story. One time she went to the doctor, they asked her what her name was, and she couldn't remember her name. I mean, we're really highly functioning people that have very problematic cognitive symptoms. That's one thing. But remember, as I told you, for example, that brainstem region of the brain, because of that vagus nerve, communicates with the whole body. So an injury or infection that affects the brainstem can lead to just a huge number of ongoing symptoms. And I think that's one of the reasons why patients who, have Lyme issues or whatever, not everyone has the exact same symptoms. That can sometimes be another source of confusion for the research community, because they want people who have a label to have some very similar things happening. And so they'll try to, say, okay, we have patients with ongoing Lyme issues. All of them should have this marker or that thing. But sometimes the pathogen acts, infects different tissue or does different things. It might even infect a different brain region in different people or different stuff. So that's why not everyone who has ongoing Lyme stuff will present with the exact same thing, which also, it's more of a challenge for doctors too. They have to actually be trained to understand all the different manifestations that can happen when you're infected with one of these organisms.
My point of view is doctors can be trained and they're not. So, I mean, there's this whole, I actually totally disagree with this whole concept that doctors are short on time and that's why they can't make complex diagnoses. I actually think I make a diagnosis watching somebody on TV that names their symptoms in 4 seconds. And I really haven't been wrong when it comes to tick-borne diseases yet. So I have to say, it's really a problem in the training. I don't think it's that hard to recognize these things and to know what to rule out. It's a differential like everything else. I think that's such a cop-out, and it makes me completely crazy, and I think it's such
I disagree. I think that there's no way to give good medical care in 10 minutes with a complex illness patient. I mean, I think that, you can get a sense of what's going on with folks, but I don't know if there's an echo here all of a sudden. But I think that in order to give good care, by the time patients come to see me, they've been seeing 20 doctors, and to be like, hey, I think it's this, and this, and here's a blood test, it's not really good enough. If there was something where the medical community could kind of rally around and make an algorithm where people can, understand this, but I agree with one part, they're not being trained, but to give we schedule new patients for 2 hours. I would do the dance of joy if I ever see a patient in 2 hours, because it's always, 3+.
But the day I walked in, right, you did give me a great amount of time, and I was very, very impressed with the amount of information that you were able to give me, and it made me feel a lot better to know it. But if I couldn't talk and you just could read my story, don't you think that knowing what you know, you could have made the diagnosis?
Of course, yes. But we can't underestimate what the educational process to the patient, how much that's worth to empower them, because if you have a patient say, okay, I'm going to give you this, goodbye. Like my brother just went through my surviving brother, my one brother passed from a cardiac event. My other brother just went through a very significant cardiac ablation with arrhythmias. And the cardiologist basically said, I don't have time to educate you about this. I don't have time, I don't have time to do this. And if we don't have time to educate these patients, and they get a horrible Herxheimer reaction, and they wind up in the emergency room, because these conditions are so marginalized, before the patients and the doctors are caught between these two worlds, they'll end up in the emergency room. The doctor says, there's no such thing as chronic Lyme. What's Bartonella? And why'd you get tested for toxoplasmosis? They're going to get a million different opinions from a million different doctors, and they're not going to be educated enough because we only have 10 minutes to give the patient. So I do think that if I were to give 10 minutes to a patient, and even if I could gestalt it and know what to do, it would be bad outcomes, because the patient would end up thinking, well, my 10 doctors are right, because I didn't really get a sense of what, Dr. Phillips was talking about, because we only had 10 minutes, And I do blame the medical system for making it this way, for making it so that patients are stuck and they're not getting the education they need. I also agree that doctors are trainable, But I just don't. The only thing I disagree with Dana truly is that it's the cop out that is saying like it's not enough time, because there's no way to go through 20 years of complex chronic illness in patients in 10 minutes. I mean,
I understand, but I guess the thing that bothers me so much is I think we need to start a movement here about when you see chronic symptoms and autoimmune disease, and there's no other explanation, there's no diabetes, there's nothing we can point, there's no cancers, things that we list all the things in the book that you should rule out, and that's really important to do. When you rule those things out, why can't doctors start considering an occult, a stealth infection, an infection why can't they start looking for Lyme, looking for herpes viruses, looking for Bartonella, looking for Babesia?
They should be. They should be. We should blame the medical associations that are dismissing and marginalizing these patients. Doctors are like kind of cogs in a wheel. Most doctors are seeing 30, 40 patients in a day, and they're trying to have these guidelines to maximize efficiency and expediency. And these guidelines, certainly the Lyme guidelines, I feel about them. I mean, guidelines aren't always right. And I think it starts from top-down training. The doctors have to be educated properly, and the medical system has to kind of be neutral on this instead of dismissive. And it's a really, really complex problem. And I know doctors who call my office, no exaggeration. I've had this happen so many times I can't count. Doctors saying, you're right. I think that everything you do is right, and I absolutely cannot do this. And what more, how is that more epitomized than the more than 100 chronic Lyme patients with chronic illness who happen to be physicians that I've treated in my career that do not treat Lyme? Almost none of them will treat a Lyme patient because they can't deal. And I've had a few doctors that came through my office to try and train them to take over my practice. I'm getting older. I'm 55. I've been doing this for a long time. I've treated over 20,000 patients. We've had doctors come through. They're like, there's no way to learn all this. Like, they have no background. There's no teaching, unless they're motivated. What I always wonder, if my dad didn't almost die from Lyme and almost need a heart transplant, would I have spent all those years going down every rabbit hole trying to figure this thing out? It's just not,
It's a paradigm shift, though, and you're speaking to it. But what I'm saying is, instead of focusing on treating symptoms, we should be focusing on treating root cause. Okay, because nobody's ever going to get well. I would have been relegated to a fibromyalgia, MS, anxiety and depression diagnosis. I would have been on 4 to 6 drugs within the next probably year if I lived through it. And I was in heart failure. So add that to the mix. Okay. And now I'm on nothing. So I'm really angry about this. And I don't think it's acceptable. And that's why I'm calling it a movement that has to happen.
It's a human rights movement. It's a patient rights movement, right? It's and I would be on biologic immune suppressants, and they probably would have killed me. So I definitely would have been disabled. I was so far gone. So we both feel the same way. I think that it's unconscionable what's going on. How do we change it? How do we have a plan? When obviously we just went over so many complex aspects to this illness, and the bottom line is, it's like overload for these doctors. They can't deal, and they just put people. They say you have post-infectious. It's so much easier to say you have post-infectious or post and get out the door. And I think that they're taking the avenue of least resistance. They're not committed. Right. They don't have skin in the game. They don't have parents who almost died from Lyme. They didn't die from Lyme. These are healthy, just doctors who are 45 years old and they want to just go play tennis or after their practice or something. Yeah. I'm just saying.
A problem is that
it's easy to give antibiotics. I'm sorry. I think it's just as easy to give a round of tetracycline or Mepron than it is as it is to give Enbrel for the rest of somebody's life. I think there's a huge financial motivation in all this, but we don't.
So do I. I'm just saying. Just speaking as a doctor, it's I understand that. I think they should all kind of get their nerve up and do this. I do. But what doctor wants to risk their career if they don't have skin in the game? Just telling you how, speaking knowing what doctors go through. Do you think they want to risk their, how much money they spent on education all the time to be trivialized by their peers and considered some, low person on the totem pole now because you take Lyme seriously? Yeah. There's a lot of, if the system was normalized, if the medical system was as it should be and said, wow, this is a significant illness. This is a huge patient burden. People are chronically ill. This is a travesty what's going on. If they really kind of got it together like they should, the doctors would follow suit. I'm telling you. Mm-hmm. And I really blame the higher ups. I don't blame the doctors who are running like on their hamster wheel. They can't. I like blame them a little bit, you know. But I know the pressures that they're under, and I don't know. That's all.
Yeah, I think one thing though is, you know, it's difficult for doctors that exactly haven't had enough training, is that if you put a patient on an immunosuppressive drug, they actually generally feel better for a bit. Because what happens is there's some form of ongoing inflammation. The root may be an infection, but what the immunosuppressive drug does is just knock down that inflammation. A little like if you have a headache and you take an aspirin, it's not getting to the root reason, well, like a Motrin or something. It's not like going to cure your migraine or something, but it tamps down the inflammation. So you feel better for a little bit. So patients will sometimes walk out of a doctor's office, they've been given an immunosuppressive drug, and they come back to the next visit and they say, I feel a little bit better. The problem is if you check back in on that patient a year down the road, 2 years, they're no longer feeling better. Because what happened with the immunosuppressive drug, it knocked down the inflammation, but it had to knock down the immune system to do that. And what happens is the underlying infection, if it's still there, then proliferates and it spreads and infects new body sites and tissue. So over the long term, they're getting worse. But sometimes doctors just see that initial sort of, I got a little bit better on the steroid. I got, you know, and that can lead to a confusing narrative that that's helping. And the other thing, Steve, is when you mentioned Herxheimer, that's a real challenge, because a lot of times, if you're going to target a pathogen, you have to feel worse before you feel better, because the immune system has to work it out. In simple terms, the immune system is going to have to, it's a battle has to happen where the immune system goes after that pathogen. The pathogen's going to release toxins as it dies. All of that increases temporarily symptoms, but in the name of good, you know, it's like, this is what we want to happen. But then the patient feels worse for a while. And so sometimes doctors will give, you know, I've known really well-intentioned doctors that don't understand the concept of Herxheimer, or that there is going to be a battle between the immune system and a pathogen that makes you feel worse first. And so a patient then says, I feel worse. And they go, oh no, you know, instead of saying that's the necessary thing that needs to happen for you to heal. And so what happens is, you know, for example, our research team a while ago tried to set up a trial for a drug that could stimulate the immune system to help people better fight persistent infection. But as part of that, people were going to have to deal with Herxheimer or feeling worse over time. And we weren't even allowed to test the drug that way. We were told that as part of the clinical trial for the drug, if a patient felt worse, then we were required to give them a steroid to knock down the symptom. And
really?
Like, that's not possible. Then that's not the treatment, right? So we have to have a treatment, you know, in cancer, for example, we're willing to accept that patients feel worse during the course of therapy. Chemotherapy makes people feel worse, and we accept that. There's new T-cell immunotherapies for cancer. They also make people feel way worse. But over time, that's what really helps them get better. We need to move that paradigm of it's okay to feel worse for a while into these other chronic conditions where otherwise feeling worse is always, you know, is a reason for steroid use.
Yeah, no. Why is it okay that people feel worse with these? Because they're accepted conditions and it's like canonized. And that's what I'm trying to say. Like, if the community can support the truth of things instead of fighting tooth and nail, like I remember I put a patient on simple doxycycline that I was on for 3 years for acne, and I had 2 zits the whole time I was on it. Okay, and I remember I put a patient on this, and she went to a neurologist. She had a Herxheimer, and she felt a lot worse. Her headaches were a lot worse, and she had numbness and tingling that were worse. And the neurologist literally said to her, "I cannot believe you took that drug. That is poison. You have ruined yourself."
Yes.
And this is what I'm faced with. So if I see a patient for 10 minutes and there's no bond of trust to say, look, I'm not a cowboy, I think about things a lot. I overthink obsessively. Like, I think about things, I grind, you know, stuff, overanalyze it like this fine pulp, you know. I mean, you know, in 10 minutes, people don't know that I'm spending really hard effort thinking about the consequence of actions. And for these doctors to sabotage these situations, this happens all the time to some degree. And whether it's just a simple thing like an eye roll when they go to the primary care doctor, the doctor says, okay, the patient, these clues, it undermines everything. And that's why in the current state of affairs, there's no way to treat patients with 10 minutes. There's a way for a doctor to know the truth. There's not a way for a doctor to implement the truth.
Right.
That's the problem.
And that even adds into the antibiotics are bad narrative, because I've known patients exactly who say, well, I took, X antibiotic and I felt worse. So see, it was hurting me. And I'm like, no, that probably indicated that you were targeting an underlying infection that you should have stayed on it, Right. So that knowledge isn't out there. And then it actually, ironically, sometimes gives antibiotics a bad reputation. So, as you're saying. So, there does have to be a huge change in education for people and doctors to understand that, getting better doesn't always mean always feeling better. You're going to have to go through periods where you're going to, like a cancer patient or something, have to deal with, the effects of the treatment.
One thing I think is really important for us to talk about before we move on from immune suppressants is, I think what really people don't realize, and we have talked about this before in other videos, but I'm not assuming everybody watching now has seen them. Immune suppressants suppress your body's ability to fight infection. So when you are on an Enbrel or an Otezla or whatever, and there's an underlying infection that was causing the symptoms that you were put on this drug for, or multiple syndromes, you could have 3 autoimmune diseases and be put on, these drugs. You allow, at the end of those commercials, when you hear new and worsening heart failures and cancers are driven often by infections. People don't realize this stuff. I think this is so important. Heart failure can be driven by infections, as it was in Stephen's dad's case, in my case, millions of his patients. And I just feel like this needs to be known, because people might think twice before taking that shortcut, that way out, doing a little more investigation, searching harder for the root cause. And I'm sorry that the onus has to be on the patient, but that's actually the truth. It's why we wrote the book, to empower patients, to bring it to their doctors, to actually educate people. I'm still maintaining that I don't think it has to be this way, because I think at a teaching level, if things change, the paradigm can slowly change.
I agree with you. I totally agree with you. But Dana, I'm just saying, doctors, if you just tell them, take your 10 minutes. We have to change how the medical schools give their education. We have to change we have to do our movement. This is a big task ahead of us, to change how doctors are educated, to change how, right. I have 10 minutes next Wednesday. I'll pencil it in. Yeah.
Yeah.
It's crazy.
No, the first side effect of Humira, if you look, is increased risk of infection. So, if you have an underlying infectious condition, that was the big irony, for example, with Crohn's disease or ulcerative colitis, is there's a mass exodus of patients who are trying to get off immunosuppressive drugs for those conditions, because, a while back, those were considered to be sterile, inflammatory conditions of the gut. And then it was discovered that humans are full of organisms, trillions of organisms. That's the microbiome, and especially the gut. There's just huge communities, ecosystems of interacting organisms in the gut and the colon. And it turns out that in Crohn's disease and ulcerative colitis, it's an imbalance of those ecosystems where pathogens proliferate and, take up space that used to be occupied by less, pathogenic organisms. And there's a total shift, what's called dysbiosis in these communities. That's the driving most of the inflammation. And yet these patients were on immunosuppressive drugs, and the number one side effect was increased risk of infection. That's what's causing the disease. So, that what happens is that there's the same trend. People felt okay on the immunosuppressive drugs for a bit, and then they, crash, whatever, need a higher dose, need another dose, need another immunosuppressive drug, right? So I think it's really interesting to look at those illnesses and say, if Crohn's disease ended up being a disease driven by organisms, and that immunosuppressive drugs didn't play out well for that, then should we really move that paradigm into the next chronic disease, especially as we understand really there's been an explosion of research in the last couple of years that shows that those microbiome organisms are in most human tissue and blood, the liver, the bladder, the pancreas, you name it. We're not sterile. No. So anytime that you're on an immunosuppressive drug, you also risk that these ecosystems and organisms that are in you can take advantage of that and change to be more imbalanced and more problematic as well. So you don't even necessarily have to have a problem with one pathogen. You might have a collective problem with communities of organisms moving towards a state that doesn't promote your health. And none of that benefits from immunosuppression over the long term.
Again, complex topics that is summarized in a 2-line thing by what they're trying to put people in a box now with post-COVID and obviously post-infectious. It's really egregious that the complexities and the nuance and all of these things are not being taken into account. Like my diagnoses were rheumatoid arthritis and a type of arthritis of the spine called spondylitis. And obviously I don't have those things anymore. I don't have arthritis anymore. I don't know if people know what C-reactive proteins are, but it's a measure of inflammation. Before I got sick, my CRP, it's called C-reactive protein, is it was 0.5. And then when I got sick, it went up to 108. And then now I just had blood tested a few weeks ago. It's down to 0.5 again. And you say, people can get rid of inflammatory conditions that are presumed to be sterile if you get at the cause of these inflammatory conditions. And it's not something that was met with any happiness when I brought it to my rheumatologist. When I got well at my 3 different rheumatologists, I went back and said, look at me, I'm so much better. Look at my blood tests. Look at my joints. Look at me dancing. I move around. And I said, isn't that going to change how you affect and treat your patients? And like, no.
Like, oh,
congratulations. But what's that?
They're like the power of placebo.
Oh yeah, give me that placebo any day.
That's what I always feel people get, where they're like, oh yeah, well.
It is amazing to me that these kind of semi-miraculous, turnarounds are dismissed, and it doesn't impact on how people practice. That's a whole nother discussion about bias and how we take in information, confirmational bias. It doesn't agree with the preformed narrative. I mean, to be looked at like I'm some weird species, like some one-off Martian, when I'm just a regular human, even with I have the small ear canals or whatever, but I'm still just a person. And for me not to be taken it should be representative of the population. I mean, there are other patients who likely get benefit if they were treated in a similar manner. I would put an open challenge if any rheumatologists are watching this video that you could send me a few of your patients, and I'll send them back to you in a year and a half, and we'll see how they are.
Can we open that up to ID doctors, please?
Sure. ID doctors, they're not treating post-treatment Lyme disease. They're sending them away. So what are they going to send me? Send me the patients that they don't treat?
Yeah. I mean, they can send you the ones after 3 weeks of doxy, like me, that come back and say, I still feel horrible, and in fact, I feel worse.
Okay. I'll take those on too, I see them anyway. I always encourage patients to also please go back to your doctors. And they rarely do, because nobody, most people are not confrontational like Dana and I tend to be. They don't go back to their doctors and say, this is what helped me. Why didn't you do this? But they should, because it's going to help the next patient. Even though it's an uncomfortable conversation to have, it doesn't have to be like a nasty conversation. You can be like, look, I want to affect change. I want to help the next person. It's like I got help somewhere else, but I want you to be empowered to empower the next person. And it's like a domino effect. And I think pay it forward kind of a thing, whatever you want to use, whatever terminology.
We need also a public face-off with the two of you and some other people that are keeping this message from being put forth. Is extremely, to me, it's one of the biggest crimes against humanity. There are 50 million people, this is before COVID, that suffer with chronic and autoimmune disease. Just in America, this is a global pandemic. So when I hear this stupid stuff, Twitter makes me crazy. Like, oh, this patient, they died 5 months after COVID. They were 40, but they were immune suppressed. So are 50 million other people, stupid.
Purposely immune suppressed. Yeah.
It's a ridiculous thing to say, and it's offensive. It's like saying if you have she had brown hair. Well, a lot of people have brown hair. So, I mean, I think it's like a terrible way to sort of couch it as if it's so rare. think we have to stop saying that these things are so rare. And I think we have to know that if we have ongoing symptoms after an infection, it is very possible and should be on the table. This goes for COVID, this goes for Lyme, this goes for ME/CFS, and also for mono. We have to consider that there is still an infection at play, whether it's the original infection or others. I think this is the message that has to be driven home for patients to get well. I don't see a path to wellness unless this truth is exposed and known.
I do. I think patients need to push back against the mystery narrative, which is what could be happening. You know,
or just your genes. All of a sudden, your genetics changed. What did my genetics change overnight? You know, before I got bug bites while I was sleeping, I could run 5 miles and play tennis all day. You can't tell me my genetics changed into rheumatoid arthritis and ankylosing spondylitis.
No, I mean, there's a researcher trying to study ME/CFS, for example, as a genetic disorder. And how do you even explain that people have relapsing, remitting symptoms, that they crash, that their nature of their symptom changes, that they have swollen lymph nodes, sore throats? That's not a genetic disorder.
And case clustering. I mean, there's many epidemics of it. Yeah.
Right. So there's sometimes where I do think, you know, patients right now, for example, if you look at most articles on long COVID in the media anywhere, it's like, what could be happening? We don't have any clues.
Right.
We have so many clues. That's why it's so frustrating for us all.
Don't you think the organism could still be in my body? You know, you can start to throw out some logical possibilities. Is there any chance that this infection kicked up something in me that was already a problem? You know, I mean, like, or, you know, what about my microbiome? Do you think the infection could have dysregulated my immune system and my microbiome is not in good shape? You know, there are some really straightforward, tangible things that can be studied and that can also be, you know, looked at. And so I think, you know, that the narrative that this is a big mystery and that, you know, a narrative, especially in the ME/CFS community, that drives me crazy is what a mystery. Despite so much research in the 1990s, especially beautiful research they found enteroviruses, which are RNA viruses in patients' stomach samples, in their muscle samples, in their brains, you know, human herpes virus 6 as well, big candidate. Then got replaced by this new, it could be a human genome thing, it could be this, and then all of a sudden this, must be a mystery then starts to become a dominant narrative. No, we need to pull back and use logic. It's not, there's not a mystery here. There's just a lot of really obvious leads.
So let's talk about what patients can do. Like I said, it's all about, I think, we'd like to really empower folks and promote patient rights and things like this. People, I'm looking through the scrolling of the comments, people, you know, talking about not great experiences with their doctors and doctors that don't listen. It is a common thing. And I still think it's worth trying. You know, some patients have good relationship with their doctors, and this is a message that needs to be spread. And how do we go about doing that? I'm not sure. I would say share the book is a reasonable thing. You know, the book was written for both professionals and lay people alike. And I know that I've shared it with a number of doctors and had really good comments back from those doctors. These are doctors that I know, so I had relationships with them, you know, but they weren't Lyme doctors. They're just like, wow, I had no idea kind of comments, which is always nice to hear. So if they're saying that, then I know that other doctors can get benefit from this information. And this book is just the vehicle for the message, really, you know, to kind of propagate this kind of message, movement, whatever you want to call it. But patients have to feel heard and be heard, and action has to actually been taken, not just placating and saying, you know, fine, and then nothing ever happens, because I've been doing this 25 years and not much has changed. I hate to say, it's really very, very sad. And I can easily see it go on another 25 years unless something is put in motion. And how does that happen? I mean, we have social media, people can have group meetings, and I'm just throwing out ideas. I don't know. I don't claim to be a social media expert or anything like this. And before this, you know, I was never really on social media before Dana walked into my life. So, you know.
Okay, I'm sorry, Steve.
No, I thank you for it, because we're getting a message out to a greater audience. But Somebody that knows more about this than I, can help move along.
I would say for patients, educate yourself. It's actually not as hard as you think. Once you basically understand pathogens, they do similar things. They create similar proteins. You can really start to understand these common trends, and you know what? They're actually fascinating. It is actually truly interesting to better learn more about organisms and what they can do. There's really cool history on this. There were fascinating scientists involved in everything. So actually, it's really, one of the things that I think a lot of people who are sick, the more knowledge you gain, the more you can sort of understand what might be happening to you. That's really actually helpful mentally. It gives you strength to do treatments, keep going. It's a source of empowerment to be able to better picture what might be happening in your body. And I think the second thing too is patients in different illness communities tend to fight with each other. I mean, not big time, but you have patients in the ME/CFS community who disagree with patients in the Lyme community, and then there are people who have lupus and other people with endometriosis, and I understand there are valid disagreements sometimes over different topics, but overall, if patients really joined together and said, let's set our somewhat separate differences aside based on diagnosis, and together just say, we need better care and better research on root cause drivers of our conditions. And we join into it, and they join into a common message of those key themes. That would really create more pressure for that to happen. Because right now, the fact that different patient communities already fight with each other, that distracts from the common, most important goal of really changing the system and care. And research.
Well, and there's so much in common. We all have so much in common.
Exactly.
The three major groups right now, which are long COVID, chronic Lyme, ME/CFS. They are infection mediated, at least in a great number of them, in my opinion.
And the hardcore autoimmune groups, I think there's a lot of ownership to diagnosis, and there's sometimes resistance into looking at the infectious causes of things like MS and RA. But I'm here to tell you that my autoimmune disease was definitely caused by infection. Nobody's going to convince me otherwise. I went from near death and complete disability. I didn't walk for 2 years. I couldn't turn over in bed without assistance. I had 24-hour home care. You don't go from I wasn't just disabled from my job. I was disabled from every aspect of life. And now I have a full life. And, nobody can tell me that my genes changed one way and it flipped this way and then it flipped back. The only change was a bunch of antimicrobials. And I use the term antimicrobial instead of antibiotics, because people should realize, some people that, have seen our other videos know that there are a lot of drugs and supplements as well that aren't strictly antibiotics, and also powerful effects against these infections. So we can design regimens that are super microbiome friendly.
Yeah.
I want to come back and talk to you, Amy. We've been here for a long time, but I want to talk. I think that Steve will agree. We should just talk to you at some point, do another Facebook Live, just about the microbiome, because there's so much propaganda around it. It's very similar to Lyme. It reminds me of Lyme. As I've gotten to know you over the last couple of years and learned so much from you, everything you told me about the microbiome is completely different from what I read on mainstream news websites or whatever. So that's one thing. The other thing I would like to talk to you about is antibiotics and the truth about them, because again, lots and lots of misinformation. I don't know if it's willful. It feels crazy to me to know the truth and to know how much better I got from some simple antibiotics and antimicrobials, and how doctors are so afraid of them. But you know a lot more about the real truth of this than as much as anybody. And I would really like to think.
Yeah, you added some amazing nuance to the book about pathobionts, because people tend to paint it with one brush and not realize this is a lot of colors to this picture.
I'd love to talk about that. The microbiome was my first area of research, and is always basically the whatever closest to my heart in a way. And yes, it's definitely not portrayed to me. It's one of the most oversimplified topics out there. And I think that the public can definitely handle a much more broad and nuanced understanding of what these organisms in and on us are doing. And they're not just good or friendly, not by any means. They just colonize us. and they survive. They do whatever, like any organism anywhere, they do what's best for their own survival. And so sometimes what they do for their own survival is in harmony with us, and we, live in a relative state of harmony. But under conditions of imbalance or immune suppression or stress, they can change the way they act to act more as pathogens than good organisms. And that can have a huge impact on us. And so a lot of the organisms that can cause chronic disease symptoms, you don't even need a new infection. I think this is what's really important to understand. You don't have to have a new dramatic infection. What can happen sometimes is that an organism that's already part of one of these microbiome communities can change its activity and the genes that it's expressing and the proteins it's making to cause disease. And it's just already in you. So there, again, it's the activity of these organisms in the microbiome that matters. And yeah, we could definitely talk more about that later.
Okay.
Yeah.
Okay. Sounds good. Do you guys want to go over any questions? We have a huge list of questions. I specifically did not look at the questions. I wanted to be a good person and not look away.
Because I can see them on my cell phone. That means that you get a break. I can.
Okay,
I didn't.
Okay, good. Because my eyes are terrible, and I'd rather you look through them because that's better.
I know. I always feel so bad when you have to moderate this because I know how much you want to answer all of them, and I do too. But I know we don't have time. And the last thing, Amy, I want to say before we go on to a couple of questions is we need to talk about congenital Lyme and congenital worlds because that's another huge scandalous situation that's driving so much illness in kids. And mothers can be asymptomatic and actually pass Lyme along to their babies and Lyme-like organisms and have kids with all kinds of issues. And
the babies can be asymptomatic for a period of time, similar to syphilis. So it is a scandal that there's more evidence about transmission of the Lyme bacteria than there is for so many other vector-borne bacteria that are spread by bugs, that like babesiosis, for example. I mean, that's accepted. And yet Lyme isn't, and all the data about Lyme. And it's kind of crazy. It's even Bartonella's accepted, and Lyme is still, they're fighting about it. It's really nuts.
It's crazy.
Yeah,
we should
because it's the Lyme word. Everything attached to Lyme.
And also, the microbiome is inherited too, like the organisms in and on us. And so if those organisms are already imbalanced or not acting in your favor in the mother, that can have a huge impact and on the child. And also that's one of the reasons why diseases can run in families is that people often inherit like imbalanced communities of organisms that contain pathogens in them from their parents. And what that means is that if a disease runs in a family, it does not have to always be a genetic problem.
Right, thank you.
An inherited organism problem. And that is really important to understand.
Or common exposures like the bad cat in the family.
Exactly.
Bad cat. That's our next book, Steve.
Yeah, the bad cat.
We're going to write a children's book, The Bad Cat. But no, I think that is so crucial. What you just said, honestly, when we first talked about that, and we talked about that in the book, it rocked my world because people misattribute infectious congenital diseases with genetics constantly. Like my mother has RA, so of course I have MS. We have autoimmunity in the family. No, you have Lyme and Bartonella in the family, and you don't. Like my mother. Okay, I'm just gonna. Hi, mommy. How are you? My mom is.
Hi, Hetty.
My mom has just a very casual logic about her. Sometimes, mom, not always, but sometimes. And with medical stuff, she's always been like that. And like a couple months ago, my grandmother died at 47 of breast cancer. That's her mother. Okay, that's extremely, extremely young, and it was a terrible, terrible death. And because it was so long ago that the tumor wasn't sequenced, nobody really knows. But there's breast cancer in my family. And my mother got a really weird HER2 positive virulent breast cancer a couple of years ago. You're not really supposed to get the kind of breast cancer that she did at her age, at her very young age, but still not supposed to get that breast cancer. Okay. So my mom said to me, I have a feeling that my mom had Lyme and that it gave her, or Bartonella, and gave her, she talked a lot to Neil and talked to him a lot about how pathogens and how these things drive breast cancer and other tumors. She said, I have a feeling my mom had Lyme and gave it to me, and that's why I got it. And then you had Lyme your whole life. Like, it's just so logical when you know, to civilians, and yet we can't get this message to be accepted. Okay, so Dr. Amy, we have a question from Pam Michelson. This is the hot topic of the day. Dr. Amy, any contact with Dr. Ron Davis at Stanford, who's looking into ME/CFS and the relationship into long COVID? Have him look at Lyme. Well, that's definitely a common refrain that I've heard. So,
I'm aware of his research team. He's actually the person I mentioned that's looking at ME/CFS as a largely genetic disorder. So I don't know, since I don't see it that way, we don't collaborate too much.
Yeah.
I know. I think that they're trying to do a long COVID study. The study, I think, is not sure what's going on. It's largely based with blood and I think cerebrospinal fluid. So I would say that one thing that they should keep in mind is that the COVID virus would not be expected to be in the blood, and neither would really be some of the other pathogens that are important in the ME/CFS or long COVID cases. So I hope there's just a little bit of awareness on that with some of their long COVID work.
I'm really shocked that he's not looking at pathogenic reasons for this syndrome. I didn't really know that until very recently, because a lot of people have told me about this new book, and very shocking to me. Okay, Jill Padawar, hi Jill. What is monolaurin used for? Is it under the umbrella of antimicrobials?
I can answer that because it's my favorite supplement. I always said if I wasn't a doctor, I'd be a monolaurin salesman, or I'd work at Costco. Because I have a set of pots and pans that are literally 20 years old, and there's not a scratch on them, stainless steel. So monolaurin is made from coconut. It's derived from coconut oil, from lauric acid. It's a naturally occurring substance in breast milk. It's not an antibiotic, yet it kills many pathogenic, meaning disease-causing bacteria. It's not a strict antiviral, but it kills envelope viruses, and it's not antiparasitic, yet it has activity against many antiparasitics. So what is it? It's a soap. It's like a detergent. It's like nature's detergent. And because it works as a soap, it doesn't work like an antibiotic. Its mechanism of action is the same as when you wash your hands and you kill 99.99% of bacteria and viruses and everything else. But interestingly, it has very little effect on the microbiome. So because it's been in breast milk for so many millions of years, we've kind of evolved with monolaurin, and it ends up being this incredibly win-win situation where it hits the bad stuff and doesn't hit the better stuff. And I love monolaurin. Monolaurin did stuff for me that I can personally tell you I've taken basically every antibiotic known to man, and monolaurin got rid of symptoms that antibiotics couldn't. Even the most aggressive antibiotics, the most dangerous antibiotics that I've taken, monolaurin got rid of some symptoms that they couldn't. So most of my patients respond to monolaurin. It's not always an easy ride. People get large Herxheimer. Sometimes they have to drastically cut down the dose right away and go up slowly. But it's one of our most used supplements. It's dirt cheap, and it's got an excellent safety profile.
Okay, great. Thank you for that. And people are laughing about your next career as a monolaurin salesman. So,
well, it's just such a great product.
It would be a lot easier than this.
Yeah, it would be a lot easier than my current day job.
In your current 4 hours of patient day job, me like going, did he eat? Okay. Sorry, I'm looking at the questions. No, you don't need a prescription for monolaurin. Somebody just asked, I get it on Amazon. I'm sure there's a million places that you can get it, and you don't need it's M-O. So Susan, somebody is asking how you spell it. MONOLAURIN, right? Something like that. Okay. Okay, so this is a good question from Terry Falvo. Thank you for your question. In your book, Chronic, which I read cover to cover, you mentioned 15% test positive for Lyme, but have no symptoms at all. So doesn't that seem like the idea that the symptoms and the bad reactions are a combination of infection plus the body's specific reaction, which may include a genetic component?
Yeah, I mean, there are definitely genetic components to these infections. Don't get me wrong. It's just that the genetics don't change overnight. So they've done studies with hamsters where they take the same exact strain of Lyme bacteria, and put them into hamsters with distinct, they call them HLA types. And one hamster gets a little bit sick, the other one not at all, and the other one, medium amount. But it doesn't mean that with other environmental, factors, like I saw one of the questions, why did he mention toxoplasmosis? Toxoplasmosis is a parasitic infection. There are many parasites that people can get that are also largely asymptomatic, but they tend to be a bit immune suppressive. When you're doing studies of a mouse or a hamster with Lyme, it doesn't represent reality. When the mouse is running through the field, it gets like 7 bacterial infections and 112 viral infections and 20 parasitic infections. And how do they work in conjunction with each other? And many parasitic infections can make it harder for the body to eradicate bacterial infections. So that's why we check for a whole litany of them. And I just want to let people know that I check for them through, chain labs like Quest or LabCorp. They're not stool tests. They're also antibody tests. And they're very easy. They're covered by most insurance, no problem. It's not any dramatic expense. It's really not, it's a non-event for most people to get evaluated for these things.
Okay. Yeah. To add into that, human genes always matter. I think one of the things though that I want to push back on is there's no disease seems to be playing out to be a one disease, like one gene, one disease model. Like when the human genome was first sequenced back a couple, in the 2000s, people really thought there was going to be the MS gene, the rheumatoid arthritis gene, the Crohn's disease gene, and it would be that simple. Right. We'd find that gene and then we'd somehow fix it. That is not played out for a single illness. But what can sometimes happen is we all have a different human genes, of course. That's what makes us different. And so if you have a gene that already sets you up to not have something so good going on in your body, and then something from the environment, like an infection, does something similar, that can compound to cause more of a problem. So for example, there are gene variants in some genes that can impact how your collagen, like your connective tissue in your body, is set up to be in the first place. But then if you get a Borrelia infection, the Lyme pathogen, that pathogen also degrades collagen. So if you had some not great genes that made your collagen not that great to begin with, and the infection, you might have a really bad case of a connective tissue problem.
And we talking about Ehlers-Danlos?
Ehlers-Danlos could definitely be, it's really at the moment only investigated as a genetic disorder, but I think it's one of the most obvious conditions in which we should be looking for organisms.
Right, definitely. Yeah. And I have another good example. I have a patient who's super lovely. I don't know if she's watching tonight, but she has a family, a very well-known genetic condition that puts her at risk of sudden death, cardiomyopathy. And so she started having some heart failure, and she had an implantable defibrillator, and it never went off. And then 7 years into it, she got Lyme, had Lyme symptoms, had positive Lyme tests through her primary care doctor, and boom, she gets ventricular tachycardia, which is a serious rhythm disorder, and her defibrillator went off. And the question is it, again, another example of, I think there's so many examples of this, like genetic predisposition and the environmental, I don't like to use the word trigger though, because it implies one and done. The environmental secondary cause, whatever you want to call it.
One more of those things that can sort of feed into the different hits that make up a disease.
Multiple hit system.
You have some bad genes that make, some system that's, in your body not function so great. And then you have an environmental hit that also does something to that. And then that really also cascades. But the more, if you can address, you can't change your genes right now, but you can address the environment. So, that's why we're really going strong on, like, at the very least, try to get at that environment component.
So doctors hate this though. Most doctors, they want things to be, like you said, they want it to be like the one gene causing MS, whatever. They want it to be simple, tie it in a bow. And this is, I don't know. Einstein said you make things as simple as possible, but not simpler. Like we want to make it as simple as possible, but it has to represent the true complexity of the condition. And this is a network system. It's not just some simple linear thing. And anyway, that's what I think.
So Amy, people are wanting to know how you feel that you can raise your immune system. Do you have any tricks and tips?
Yeah, that's a good question. So there are, I guess I'm going to start with one that I think is really applicable because almost anyone can do this. Now, the gut microbiome, remember that I mentioned all the organisms in the gut? If there's so many of them that the immune system is caught up a lot surveilling those organisms, just going like, what's going on, making sure, trying to make sure they're okay. So if most people, because diet isn't great and there's a lot of stuff, their gut organisms may not be in the best shape. They may be somewhat imbalanced or skewed. There's a lot of easy protocols where what you can first do is take some supplements that help strengthen the lining of the gut, because if the lining of the gut gets leaky, it's called leaky gut. What can happen there is some of the organisms in the gut leak into the blood, and there in the blood, they really cause a lot of inflammation to happen. And then from the blood, they can leak more into tissue. I actually think that might happen in things like Ehlers-Danlos syndrome, to be honest.
So that's a real thing. I'm only asking you this because this is another mechanism that's discredited by a lot of mainstream doctors. Even I just talked to somebody, a writer, an author that's like writing a book about this now. There's a lot of like controversy about whether this condition exists, and it seems like it's logical again, but why again? Do you find that it's controversial or this leaky gut? No, leaky gut.
Oh no.
It shouldn't be, right?
It's another dumb thing where some scientists don't like the term leaky gut. They think it's too casual a term or something. I don't even understand it by a long shot. Okay. The epithelial cells of the gut become permeable. Okay. But what I mean is to explain it to you in a way you'll get the gut.
Exactly.
Yeah. There's a certain snobbiness in science where sometimes researchers don't like a term that becomes used by people. And I really don't get that.
But what do you feel in terms of antibiotics? Because I literally had a patient who is doing a lot better now. And he went to see an alternative medicine doctor before he saw me. And he had seen it. I think he had gotten a total of 5 weeks of antibiotics, 5 weeks in his whole Lyme career, and the doctor said that he has chronic leaky gut now from the antibiotics and he should stay away from all antibiotics. And, within a couple of, not to brag, some patients are really, it's hard to help them. And I definitely, strike out sometimes, but he's getting better quickly with additional antimicrobial therapy. And I do think there's sometimes danger in attributing leaky gut to antibiotics when this is not necessarily what's going on.
Did they have a concrete reason for saying that, or was it just an assumption?
No. She referred to it as saying that because of his chronic antibiotic use, and the net total of the antibiotics was I think a 2-week stint and a 3-week stint. And that was it.
No, I wouldn't think personally much about antibiotics causing the gut to be leaky. It's actually the inflammation from imbalanced organisms that causes the gut to be leaky. So antibiotics are actually a pretty useful tool for containing some of the, more pathobiont kind of pathogenic organisms that can be in those communities. So no, that's not actually something I would think of.
But the prevailing dogma among alternative medicine doctors that antibiotics causes leaky gut, I hear it a lot, and I don't see that by patients. I mean, I can tell you that again. I would just if I saw patients come in with normal GI tracts and then walk out with horrible chronic problems, I would say it because I wouldn't pull my punches. I get so many patients, and I myself, I had 2 endoscopies. Like people always hear when they hear my story, they want to hear, "Oh, you didn't walk for 2 years," and "Oh, you almost died," and blah blah blah. And hey, I had really bad reflux. It's not so exciting to say I had really bad reflux, but I got 2 endoscopies. I was on round-the-clock Dexlant. My stomach was a mess, and it only got better when I got effective antibiotics. And until then, it never got better. So I had so many GI symptoms from the actual infection, and that's what I was. I've had patients come in with feeding tubes. I've had patients come in that have had multiple pieces of their colon snipped out for unknown reasons. These are people before they've even touched treatment. So I think it's important just to say, because I get a lot of pushback from this from different, areas that the illness themselves, the infections themselves cause a tremendous amount of illness related to the GI tract. But people are so overly concerned about what antimicrobials could do. Well, when I see people who've gotten, 6 surgeries on their GI tract because of the illness, I would be more concerned about what the illness can do.
Yeah, no, I mean, I think, you don't want to take endless rounds of antibiotics for not good reasons. It depends why you're being given antibiotics. I mean, there's sometimes people are given antibiotics for a cold or
virus.
Doesn't like, you're like,
that makes me crazy.
Take it, you know, that, but if you're giving an antibiotic for a reason, then that is probably, you should go ahead and take it. I mean, you know, for example, there's a revolution now with UTI that I think has been so long in the making, where there are now a couple companies, and I, you know, like the way you sell monolaurin, I could be a sales rep for this company, Microgen, if I wanted to, where they're doing, you can do a urine sample or a vaginal swab sample if you have a UTI, and they can use some of these new computer-based tools that can identify genetic material of organisms in those samples. And they can tell you the exact organisms that you have in your urine when you have a UTI, and it changes the game, because a lot of times patients they just guess the antibiotic. I hope you have E. coli, you know, and that can be dumb because you might have an organism and you're taking an antibiotic that doesn't kill that particular organism. Yes. That's just a waste generally. Why are you doing it? And that gives, you know, antibiotics a bad rap. Hey, it didn't work. It's another thing. So what this does is also just, we have now better tools to be able to understand what organisms are in a sample. And if you can target an antibiotic, now that, you know, so this report from this company, they'll list out the pathogens or organisms, and there's sometimes multiple pathogens in the sample, not even just one, and just recommend an antibiotic off of that. People do so well. It's just, you know, you know, I think antibiotics, it goes like this.
It's nuanced.
Yeah, I mean, use an antibiotic with intelligence. The more you can understand the nature of the organism you're targeting, the more you can use an antibiotic that really targets that organism. That's great. Do it, whatever. You know, don't take antibiotics unnecessarily. Don't take antibiotic just because you have a runny nose or something. Yeah. Just take them with intent and when they matter. But when you do that, that's a very important and useful tool. Yeah. And I don't think that is a big problem for leaky gut.
Yeah, no, so great. I mean, I think that the problem lies in painting this with one brush. Antibiotics are terrible. They'll wipe out your microbiome forever. You take one course, it's all gone. Or antibiotics are great. You should be on antibiotics for your life. I mean, people like, you know, you have to find what works for each patient. And I wish that it was easier and you didn't have to do trial and error.
With antibiotics, another way to use them intelligently is take some probiotics or eat some fermented foods after you're finished with a round of antibiotics. It's actually kind of a good opportunity to repopulate your gut with some better organisms. So for example, if I take a round of antibiotics, I'll eat some sauerkraut, some kefir after. I take some probiotics, kind of repopulate with some organisms that like are, I don't say beneficial, but they're ones that you don't, you know, kind of natural and that are good for the gut, you know, overall. And, you know, kind of just come back and add some organisms back in, the gut come back, you know. So, yeah, there's all kinds of strategies that people use to just, you know, use antibiotics.
And I could just also tell you that before I was on disability, before I got sick myself, I was treating like most of the other Lyme doctors were treating, which is, you know, straight through antibiotics and thinking of them as all the same. And then when I reformulated how we treat patients, we get very, very little gut dysbiosis, because you can measure how much C. diff colitis, Clostridium difficile colitis we're getting. We used to get one case a month for years. And now we've got a couple of cases with the current regimens that we use. And I mean, those couple of cases were outliers. You know,
a couple cases over how much time? A couple cases
8 years. 8 years.
Right.
I mean, that's incredible. Right.
You can also use, you know, antimicrobial supplements to improve the gut microbiome as well. You don't have to always go the antibiotic route. You know, it's kind of like
we have some patients. Yep, we have some patients who are just we have some patients who don't want any antibiotics.
So yeah,
can you go back?
Oh yeah. So first, quickly, like you strengthen the epithelial lining of the gut, and then you can take some different supplements that kind of, you know, wear down bad bacteria in the gut. And what that does is that kind of allows the immune system in the gut to get a little bit of a break from having to surveil all those organisms. And that can help it bounce back and just better figure out if there's more problems in the rest of the body. So I always actually tell people to do some of these basic gut microbiome protocols when they're trying to better support their immune system. Is just a good place to start. I mean, that's just one, you know, going back to
do you have any comments on butyrate?
Yeah, I don't, you know, so organisms in the gut, they make different compounds, and butyrate's one of them. I haven't gone that route personally. I take a couple of probiotics and none of them are butyrate ones. That's actually just not my area of expertise. I don't know.
Okay. No worries. It's not my area either, to be honest, but I know some some patients have gone down that route and say that it's helpful. So I learned from my patients, like I think we should, I think when doctors stop, learning from their patients as well as their medical societies, you should learn from both, I just think that's important. So I know that, let's take another question. Yep.
No, I'm just going to see if we could take one more. I'm just watching the questions and how smart and educated these viewers. And I mean, I just can't even believe how much patients know now. And sadly, because we're forced to know because our doctors know so little. My battery on my computer is about to die. Okay, I'm going to, if it's okay, I'll ask one more question from Heyday Floyd. Can you go back to the leaky gut? And what can this regular person do? Is there a type of probiotic or prebiotic that helps? I know a lot of people ask me these kinds of questions. I'm not really sure the answer. Maybe you can shed some light before we go.
Yeah, not to sell another book, because you should always buy Chronic first before buying any other book.
But that is absolutely a fact.
Yes,
okay.
It's required that you buy Chronic before doing this. But after you buy Chronic, you could buy a book called the Gut Health Protocol that I think is a really reasonable protocol for strengthening the gut barrier and using a mix of supplements and dietary changes to impact that. And it mentions some types of probiotics that are commonly used.
Okay, great.
Great. Well, tomorrow. Okay, so Amy, unless Steve, do you have another question? Because my computer
I realized that I don't want to take advantage of your time. You've been so generous, and the patients I think they really enjoy this conversation. I was watching a lot of great comments, scrolling by how informative it is, and we're just so appreciative that you're here. You're a rock star, and and we want to keep doing what we're doing, keep spreading the word about these things and educating and empowering.
Yeah, let's talk more.
Can we do this again soon? And maybe we could bring Dr. Mike Van Elziger back, because we did a really fun talk with the four of us a few months ago, and people loved that talk so much. I got so much great feedback. And tomorrow morning, just have to give a little plug for for me, it's the morning. For you, it's the afternoon. Steve and I are doing a talk of very exclusive, what I keep saying, we're cool now. We'll be on Clubhouse.
I don't think any Clubhouse talk's going to ever make me cool. I don't know if that's going to work for me.
You are so cool in my eyes. I don't agree, but you're even more cool because Diana Barrett, who's so cool, who's the founder of Survivor Corps, let me be one of her 2 first invitees. And then we did this whole tour of the Clubhouse app, and I heard Elon Musk, and I was like talking in this room. I never even this has all happened, and I was like, what? It's like Soho House on my iPhone in an app. It's the weirdest thing ever. But we are doing this Clubhouse talk tomorrow.
So if anyone has Clubhouse, the problem is it's not open. It's not so readily available, though. I hear, right?
No, you can RSVP and they'll send you a link. That's not true.
Okay.
So
awesome.
Get on. There's it's on our Facebook page, and I think it's called the Great Horse Book Festival. And so it's on the Clubhouse app at 10:30 a.m. Pacific time, 1:30 p.m. Eastern time, and then. I guess we're not ready to make any other announcements right now. Am I right? Is there anything else we want?
We have big announcements. We want to save it.
Okay,
want to save it.
Okay. I always want to jump the gun, and he always reels me in. This is our yin and yang.
We're going to make some really big announcements soon. Yeah. We have a lot of big press coming up. It's all good. Very exciting stuff.
That's awesome.
Yeah, because people were sending letters saying this has to get to a more national stage. Well,
it's coming. It's coming. It's coming. We're not
going to back down. So anyway, thank you so much, Amy. You are a goddess, brilliant, and just all the good things. And my phone's ringing. This is really embarrassing. Okay.
No, I love talking to you guys. Thanks for writing the book, and we'll be in touch. Yeah.
Thank you.
Okay. Bye, everybody, and thank you to everybody that's tuned in.
Thank you so much. Thank you. Shabbat shalom.
Okay. Bye.
All right, cool. So, okay.